Assalamu alaikum. My name is Munif Ahmad. My roll number is BP1650156. I am a final prof morning student, and today my topic presentation is ephedrine. First of all, introduction. Ephedrine is a sympatomimetic amine and substituted amphetamine. It is similar in molecular structure to phenylpropanolamine, methamphetamine, and epinephrine. Chemically, it is an alkaloid with a phenethylamine skeleton found in various plants in the genus Ephedra. Now, the mechanism of action of ephedrine. Ephedrine is a direct and indirect sympatomimetic amine. Ephedrine activates adrenergic alpha and beta receptors as well as inhibiting norepinephrine reuptake and increasing the release of norepinephrine from vesicles in nerve cells. Ephedrine stimulation of alpha-1 receptors causes constriction of veins and rise in blood pressure. Stimulation of beta-1 receptors increase cardiac chronotropy and inotropy. Stimulation of beta-2 receptors causes bronchodilation. Now the rational uses. Ephedrine is used to prevent low blood pressure during spinal anesthesia. It is also used as a bronchodilator to treat certain breathing problems. Irrational uses includes it is used to treat asthma, narcolepsy, and obesity. It is also used as a nasal decongestant and also used in certain heart rhythm problems such as stroke Adams syndromes and myasthenia gravis. Now the side effects. Major side effects of ephedrine includes anxiety, headache, dizziness, loss of appetite, and palpitations. These all are the major side effects of ephedrine. Now the drug interactions. The risk of severity of adverse effect can be increased when ephedrine is combined with abaloperidide. Therapeutic efficacy of ephedrine can be increased when used in combination with acebutolol. The risk of severity of hypertension can be increased when ephedrine is combined with aceclofenac and acetaminophen. Alternative choices. Atropine is widely used to treat bradycardia and also used to prevent SAIH. Phenylephrine has largely been used to treat IAH. It increases the cardiac afterload and reduces the venous complaints. Norepinephrine is equally effective to phenylephrine. Now, moving towards the ephedrine different brands, we have some low prices and we have some high prices brands. In low prices brand, we have Rhinocene, Bronchodial D, Lignocaine. These all are available as nasal spray, syrup, ointments having different strength and they all have low prices. In high prices, we have ephedrine HCl, Esmol, Marex. These all are the tablets available in different strength such as 30 milligram, 15 milligram, and 25 milligram. Dosage forms. For the treatment of hypotension occurring in the setting of anesthesia, the drug which is using here is Ecowas for FETRA. In adults, the usual parenteral dose is 25 to 50 milligram given subcutaneously or intramuscularly. IV 525 milligram is administered slowly, repeated in 5 to 10 minutes if necessary. In children, the usual subcutaneous or intramuscular dose is 0.5 milligram per kg of body weight or 16.7 milligram per square meter of body surface every 4 to 6 hours. For the treatment or prevention of attacks of bronchospasm and asthma, the drug which we are using here is ephedrine HCl tablets. In adults, the dose is 15 to 16 milligram TID 3 times daily. In children under 1 year, this drug is not recommended. For the children aged 1 to 5 years, 50 milligram TID is recommended, and for the age 6 to 12 years, 30 milligram TID is recommended. In elderly patients, the dose should be substantially reduced. Initial therapy should be started with 50% of the adult dose. Now, for the relief of nasal congestion, the drug using is ephedrine nasal drops 0.5%. The recommended dose is 1 to 2 drops into each nostril as required, but not more than 4 times a day. The above dose is for adults, the elderly, and the children over 12 years. This is not recommended below 12 years. Now the toxicity. At higher doses, ephedrine causes hypertension and tachycardia, causes the blood-brain barrier. Ephedrine can cause agitation and insomnia. In patients with prostatic hypertrophy, ephedrine can produce urinary retention. Antidote. For hypertension, 5 mg phenytolamine mesylate diluted in saline may be administered slowly intravenously or 100 mg may be given orally. Convulsions may be controlled by diazepam or paraldehyde. Dexamethasone 1 mg per kg is administered slowly intravenously may control the pyrexia. Now, moving towards the case study. A 65 years old man reports a 6-month history of dizziness, lightheadedness, weakness, and fatigue while upright. He takes no medication and has no personal or family history of neurologic disease. On physical examination, his supine blood pressure is 160 by 100 mg of hemoglobin with a heart rate of 72 beats per minute. On standing, his blood pressure falls to 70 to 40 mg per hemoglobin. With no change in heart rate, the results of the remainder of the examination, including neurologic examination, are normal. How should he be evaluated and treated? First of all, we have the subjective. In subjective, we have a gender. The gender is male. Age of the patient is 65 years. Chief complaint of the patient is that patient suffered from dizziness, lightheadedness, weakness, and fatigue while standing for the past 6 months. History, the patient has no family history of neurologic disease. After subjective, we have objective. The supine blood pressure of the patient is 160 by 100 mg of hemoglobin, and the standing blood pressure is 70 by 40 mg of hemoglobin, and the heart rate is 72 beats per minute. Now, what is the assessment of this case study? The patient feels faintness and wooziness in upright positions due to decrease in the blood pressure. The weakness, fatigue, dizziness are the major problems of the patient. These all problems or symptoms are due to the postural hypotension. When the patient stands up from sitting or lying down, the blood normally pools in the legs because of the gravity and the patient begins to feel dizzy. For the further confirmation of diagnosis, different tests should be carried out such as blood pressure monitoring, blood test, stress test, or tilt table test. These all are the tests which can further confirm the postural hypotension. Now moving towards the plan. The major goal of the treatment for orthostatic hypotension is to restore the normal blood pressure of the patient. We have non-pharmacological as well as pharmacological treatment. First of all, let's have a look on non-pharmacological treatment. Prevent rapid changes in position, drink enough water, avoid alcohol consumption, overeating, eat a high salt diet, which is an efficient way to rise the blood pressure. Crossing of legs and elevating the head by 10 to 30 degrees while sleeping will increase the blood pressure. Now, moving towards the pharmacological treatment. In pharmacological treatment, the first drug we have is Ephedrine. It is given 10 milligram TID 3 times a day. The starting dose should be 2.5 milligram, and it should be used with caution in patients with renal impairment. The second drug we have is droxidopa, which is given 100 milligram TID, then titrated every 24 to 48 hours as needed. The maximum dose should be given, which is 1800 milligram. There is no dose adjustment. Pseudoephedrine is given 30 milligram daily. Thank you.